Welcome all for the today's presentation. Today's presentation is on the urogynecology module, and we will discuss about urodynamic testing. This topic is going to be very important from the examination point of view, especially for part 2 as well as part 3 also. We begin with our quote, Master MRCOG with concept-oriented clarity. This topic is from one of the talk on urodynamic testing. So what exactly the urodynamics is? What are the indications of urodynamics that all we are going to discuss today? So urodynamics objectively assesses lower urinary tract function or dysfunction using physiological measurements during filling and voiding phase. So what exactly it assesses? It is the lower urinary tract function or dysfunction. Okay. So International Continence Society a good urodynamic practices 2016 states that urodynamics includes all measurements assessing lower urinary tract function, that is cystometry, pressure flow studies, etc. Essential requirement is formulate a clear diagnostic question before performing any urodynamic test. So the most important thing is we should have a clear diagnostic question. That is what is the prerequisites before you put your patient for the urodynamic test. That means we need to know ourselves that what exactly we want to know about this, whether we want to confirm some diagnosis or whether we want to rule out some diagnosis, what exactly we are expecting from the urodynamic test that we should know first. Okay, so what are the indications of urodynamic investigations? Urinary symptoms such as urge incontinence, stress urinary incontinence, mixed urinary incontinence, neurological urinary incontinence, and lower urinary tract symptoms which are not explained by the simpler evaluation before invasive treatments for urinary incontinence when needed to clarify the diagnosis. Okay, so when you want to plan the invasive treatment for urinary incontinence, we need to clarify the diagnosis, and for that we require the urodynamic test. So basically, incontinence, mainly the urge incontinence, especially with respect to the stress urinary incontinence, what the guidelines is that we will discuss, but the stress urinary incontinence, especially because of the medical legal climate, we need to consider. But otherwise, pure stress urinary incontinence, we do not require the urodynamic testing. Okay. Mixed urinary incontinence, yes. And neurological urinary incontinence, lower urinary tract symptoms, which are not explained by the simpler evaluation. Before invasive treatments for urinary incontinence, we need to do this particular testing. So what are the prerequisites before starting the urodynamic testing? That is the essential clinical workup which is required. First is a comprehensive clinical history, including any medication if the patient is taking. Then we need to have the urine analysis, clinical examination of the patient, completed bladder diary, and bother score or quality of life question. So these are the things which are must, especially for part 3 candidates. If you get a scenario and you require the urodynamic testing, you need to have the complete history. Ensure that you discuss about the urinalysis or confirm whether it has already been done. If not done, you suggest that we need to carry out this particular test. Okay, before we proceed with the urodynamics, then clinical examination is required. Bladder diary should be completed. Okay, and quality of life questionnaire. These are very important. Then physical assessment should include abdominal and pelvic examination, assessment of the prolapse, vaginal and pelvic masses. We need to look into it. Then genital atrophy, we need to look for. Pelvic floor muscle tone and contractility is to be noted. And if there is a urinary leakage on staining, that we need to find it out. And focused neurological examination is required. So what are the components of standard urodynamic testing as per the International Continence Society? Okay, what are the standard urodynamic testing components of standard urodynamic testing? So basically, it has got three components. One is a uroflowmetry, second is a transurethral cystometry, and third is a pressure flow study. Okay, so the first is a uroflowmetry along with post-void residual volume. It assesses the voiding part, okay, and efficiency. So uroflowmetry along with a post-void residual volume, it will assess the voiding pattern and efficiency. Next is a transurethral cystometry. So this transurethral cystometry will evaluate the bladder feeling, capacity of the bladder, compliance, sensation, and detrusal overactivity. Okay, so this transurethral cystometry will take into account bladder filling, capacity of the bladder, compliance, sensation, and detrusal overactivity. Then there are pressure flow study. This will assess the voiding phase, detrusal contractility, and outlet resistance. Okay, so these are the components of urodynamic testing. So standard urodynamic testing will involve uroflowmetry along with the post-void residual volume, then transurethral cystometry, and the pressure flow study. Okay. When these are performed in the patient's usual position, that is either seated position or standing position, it constitutes ICS standard urodynamic testing, that is ICS SUT. Okay, so these tests, when they are performed in the usual position, that is seated position or standing position, it will constitute ICS standard urodynamic testing. Okay, now what is the bladder diary? So that is one of the prerequisite before we go ahead or proceed with the urodynamic testing. We need to have the completed bladder diary. It is just a simple non-invasive tool, and it will include fluid intake by the patient. Episodes of urgency and incontinence are to be noted. If she is using pad for the leakage, that we need to note it down. And what is the volume which is voided and the timing. So it is a sort of input output that we need to chart it properly. The pad use and episodes of urgency incontinence, that is to be noted. What is the recommended duration? So the recommended duration is actually 3-day frequency voiding chart. Okay, and it should also include the working day as well as the leisure day. Okay, so 3-day frequency voiding chart is a part of bladder diary. Although exact optimal duration is not clear, but generally it is advised for 3 days. Okay, all patients with lower urinary tract symptoms should complete this particular diary. Now, what are the key physiological parameters to understand? So we need to understand from these urodynamics, what is going to be the bladder capacity, what is the compliance, sensation thresholds, detrusal activity or overactivity, urethral pressures, flow rates, and post-voidal residual volume. So these are the things we should be able to understand from these urodynamic testing. Now, interpretation of the urodynamic results. What are the principles? The interpretation must be accurate, systematic, and linked to the diagnostic question which we are looking for. Okay, for which we are looking for the answer. Then we must consider environment may not reproduce the natural symptoms because it is produced in the artificial environment. So the test which is performed may not reproduce the natural symptoms. The patient's anxiety or artificial setting may alter physiological behavior, and quality of tracing and calibration also we need to take into account. So what are the factors affecting the interpretation? One is a catheter positioning. Second, patient's posture, feeling rate, artifacts, movement, cuffing, etc. Then presence of genital atrophy or prolapse, and neurological status. So these are the factors which will affect the interpretation. What are the limitations of urodynamic investigations? The artificial setting may not reproduce the real life symptoms. Then invasive nature may alter the bladder behavior, requires technical expertise for accurate performance and interpretation, should not replace clinical assessment and used only as an adjunct. Okay, so performing this urodynamic, it should not replace the clinical assessment. The clinical assessment, the history taking, the examination of the patient, that is must. And this urodynamic testing will be as an adjunct to your clinical examination to answer the question. Okay, so what are the learning objectives? So understand the key indications and components of urodynamics, which we have already seen. Learn physiological norms of lower urinary tract function and apply them in the interpretation. Formulate clear diagnostic questions before testing and acknowledge limitations of urodynamic testing, especially in artificial setting. So limitations also we have noted up till now. Okay. So what are the indications that we will go further into the detail? So it is performed to confirm or refute the diagnosis and identify all causes of lower urinary tract symptoms. Especially it is useful when you give conservative or the surgical treatment and that has failed. Okay, so you have planned some treatment, either conservative or surgical, but the treatment has failed. In that particular case, this urodynamics will help us to decide the further plan of action. Sometimes the patient symptoms are not very clear or complex. In the sense, you are not very sure whether it is a pure stress urinary incontinence or it is a mixed urinary incontinence, or it is just a overactive bladder. What exactly you are dealing with, that you are not able to identify. So when the symptoms are not clear, so you can go ahead with this urodynamics. So what are the hidden issues like detrusal overactivity, or there may be voiding dysfunction, and this hidden issues will affect the surgical planning. Okay. So it helps to guide the preoperative counseling, predict possible complications such as urgency, voiding dysfunction. It may be used for surveillance or research purpose, requires a clear diagnostic question that will change the management. Okay. Then it is important for the surgical planning. It helps to guide preoperative counseling, predict possible complications such as urgency, voiding dysfunction, etc. It may be used for surveillance or research and requires a clear diagnostic question that will change the management that we have just mentioned. Okay. So, as I have already mentioned regarding the pure stress urinary incontinence, there is a debate on use in pure stress incontinence. Mixed urinary incontinence has a poor surgical outcomes than pure SUI. So, if it is a pure stress urinary incontinence, the surgical outcome is good. But if it is mixed, that means you have the stress urinary incontinence associated with urge incontinence. So, here if you go ahead with the surgical option, then the condition may worsen. Okay, because it has got a associated urge incontinence also. Okay, so these cases, mixed urinary incontinence has a poor surgical outcome than pure SUI. Okay, so there is no clear evidence that preoperatively urodynamics in pure SUI will improve the outcome. So if you do urodynamic in pure SUI, there is no difference whether you perform or whether you don't perform. Okay, so if you are offering the surgery for pure SUI. So whether to do or not to do is a debatable option. There was a value trial, and as per this value trial, there was no difference in the outcome between women who were assessed with or without urodynamics for SUI before mid-urethral sling. So the patients were underwent mid-urethral sling for SUI, but there were two groups. That is the one who assessed preoperatively with urodynamics, and other group, the one who were not assessed with urodynamics. And in both the cases, there was no difference in the outcome. Okay, so practically speaking, this in pure SUI, when there is a surgical treatment which is being offered, this urodynamics may not be required. However, because of the medical legal climate, it's always better to have objective diagnosis. It's still valuable and it may avoid unnecessary surgery, and it will help us to counsel the patient appropriately. Okay. So this actually we need to discuss with the patient why exactly we are doing the urodynamics. Okay. Then what are the consent essentials? Urodynamics attempts to reproduce symptoms in artificial setting, which may cause anxiety or discomfort. Patients with depression, anxiety, painful bladder syndrome, they experience more distress. We need to give the clear information. Okay. So patient information leaflet is available as per the ICS standard. This leaflet is available that we need to provide. And we need to discuss the limitations, that imperfect prediction of cure, cannot reliably predict surgical complications, and no therapeutic benefit. So if at all we are offering the surgery, in that particular case, we cannot predict the complications of the surgery by this pre-operative test. Okay. And for children, consider psychological and social factors affecting the behavior. Now, what is the preparation? We need to follow ICS CDT evidence-based protocol for equipment and training, ensure examiner accreditation and competency. Medication. Now, few patients may be on overactive bladder medication such as antimuscarinic agents. And previously it was like that we need to stop these medications. But nowadays they say that the overactive bladder medications may be continued. So whatever is the institutional protocol that needs to be followed. However, whatever is there that needs to be documented, whether the medications have been stopped or whether the patients have been or a patient is continuing the medication. This urodynamic is tested on the patient who is taking these medicine. That needs to be clarified. Then urine dipsticks. If there is a urinary tract infection, then you have to treat it first. So you will postpone the procedure. Antibiotic prophylaxis routinely not recommended. Remember, there can be an SBA. Is there any role of this antibiotic prophylaxis in urodynamics? There is no role of antibiotic prophylaxis. And pre-testing, if you have urinary tract infection, then that needs to be treated first. Okay, and we need to postpone the procedure. Maintain aseptic technique and reduce the prolapse, pessary or speculum before testing the patient. Okay, so this is what is the prerequisites. And for part 3, one needs to know whatever I have discussed because there will be one station on urogynecology. Okay. Now, what are the components of urodynamic testing? One is a uroflowmetry. Okay, so it is a non-invasive first line test. Patient voids in the preferred position. Flow is recorded graphically. So what exactly we are looking for? One is a flow rate, that is Qmax. Okay. Then voided volume and post-void residual volume. So these are the things which we need to look for in uroflowmetry. Okay. So first is a uroflowmetry. In uroflowmetry, what we are going to, it is a non-invasive first line test. Patient voids in a preferred position and flow is recorded graphically. And what we are going to note is a flow rate. So we'll measure the flow rate, voided volume and post-void residual volume. Now, these normal values you should remember that normal female Qmax is between 20 to 36 ml per second. Artifacts may falsely increase the Qmax and post-residual volume should be less than 100 ml. Usually it is insignificant if the patient is asymptomatic. So if the volume is less than 100 ml and if the patient is asymptomatic, then it is not significant. If there is a high post-void residual volume, then patient may indicate that may indicate detrusal overactive, underactivity or obstruction. Okay, so what is the normal Qmax? 20 to 36. Okay, then we need to look for the flow pattern. Okay, now normally what happens? You get a normal bell-shaped curve. We will see in the paragraph in the figure in the next slide. So you will get a normal bell-shaped curve. There will be rapid rise followed by peak and smooth decline. Okay, that indicates the normal function. Sometimes there can be low Qmax. The curve will be slow and or flat curve. That indicates there is a decreased contractility, obstruction on or underfilled bladder. Then there can be intermittent flow which stops and starts. So this indicates detrusor underactivity or urethral dysfunction. There can be staccato flow pattern which indicates irregular fluctuating flow, pelvic floor overactivity, or there can be plateau, that is low steady flow, that indicates obstruction. Okay. See here, this kind of pattern. Okay, multiple spike. Okay, several peaks in Qmax. Okay, this is caused by the repeated Valsalva maneuver, that is straining leading to fluctuating and intermittent stream, and the possible cause is bladder outflow obstruction and unsustained detrusal contraction. So sometimes they may give you the figure, or there can be a question on the diagram. So you may get any kind of this particular pattern and they may ask you the possible cause. Okay, so here if you get a several peaks, then like this you will you need to think about the bladder outflow obstruction or unsustained detrusal contraction. Okay, see here, this is the second pattern where there is a reduced Qmax. So this is here there is a Qmax is good, okay, normal, but there are multiple spike. Here there is a reduced Qmax and then there is a plateau. So rapid upstroke but with a reduced Qmax giving a plateau shape, it may suggest a urethral stricture, external urethral compression, or bladder outflow obstruction. With example like a prolapse following continence surgery, failure of bladder neck relaxation, or a contractile detrusal. So these are the causes if there is a plateau and reduced Qmax. Then there can be very high Qmax, a rapid upstroke and downstroke. So possible detrusal overactivity and high speed squirting to overcome an obstruction. Okay. So you think about the detrusal overactivity. Okay, if you get this very high Qmax. So this is the same bell-shaped pattern. You have the uroflowmetry showing the typical bell-shaped curve and seen with normal flow with a voided volume of around 250 ml. Okay, so this is the flow rate and this is the time. Okay, and you see around it is the flow rate is around 15 ml is reached, and the total duration it is somewhere between 10 to 15, and the total duration is around 25 seconds. So around 250 ml volume is voided. The same bell-shaped curve, actually this kind of curve you see, this is the proper curve which is drawn, but the what you see in the urodynamics is like this. Okay, so uroflowmetry showing the typical bell-shaped curve seen with the normal flow with a volume of around 250 ml. Okay, and this is the volume. So this is the volume, maximum volume reached is 250 ml. Now next component is the cystometry or cystourethrometry. So what does this cystometry or cystourethrometry does? It measures the various pressures such as P vesical, P abdominal, and calculates the P detrusal. Okay. Now this detrusal pressure, which is denoted as P det, is nothing but the P vesical minus P abdominal. Okay. This you need to remember. Okay. And you also need to know when the P detrusal is abnormal. Okay. So this cystometry or cystourethrometry will measure various pressures, that is P vesical, P abdominal. It will also calculate the P detrusal, that is P vesical minus P abdominal. Okay. It uses fluid filled or air filled or solid state catheters. The standard is the fluid filled with external transducer at symphysis pubis. Okay. So what exactly we need to record in this cystometry? We need to know what is the fluid type and temperature, the feeling method and rate, catheter size, pressure recording technique, and patient position. Okay, so this information we just need to know theoretically. There will not be question on this, but this P detrusal, what exactly it is, there may be SBA also. It is a P vesical minus P abdominal. And if it is more than 50, then it is abnormal and mainly associated with the overactive bladder. Okay, that we will see in the subsequent slides. Okay, now what we do, we feel the bladder. Okay, in this cystometry, we introduce the catheter and we feel the bladder. The solution which is used is normal saline at room temperature. Okay, and what is the feeling rate? The feeling rate is around 10% of the maximum voided volume. Okay, that should be the feeling rate. Whatever is a maximum voided volume, you have to make 10% of that, and that will be the flow rate. If you are dealing with a case of detrusal overactivity, in that particular case, you go for a slower rate. So the feeling rate will be less, around 10 ml per minute, if it is a detrusal overactivity. Naturally, what happens, at what rate the bladder gets filled through the ureters? It is around 1 to 2 ml per minute. But when we are performing artificially, we are giving the high rate of feeling, almost around 10% of the maximum volume. If it is a 250 ml which is voided, we can use up to 25 also the feeling rate. But if we are dealing with a detrusal overactivity, we'll go for a slow feeling around 10 ml per minute. Okay. Now, what are the sensations during cystometry that we need to annonate? So when we will see the urodynamic trace, we will see all these annotations. Okay, so this sensation, that is the first sensation of feeling. So the bladder is getting filled. So that first sensation, okay, it means the bladder is, the person feels that the bladder is not empty now. That is the first sensation of feeling. Okay, so the patient does not feel that it is an empty bladder. Patient feels that some bladder is getting filled. That is what is the just sensation of feeling the bladder. Then first desire to void. Okay, that is a normal urge. There is no hurry. Okay, because it has got a good compliance. Okay, then next is a strong desire to void. Okay, that is the maximum capacity has already reached. Okay, so here the patient cannot postpone further. Okay, the patient has to void the urine. That is the strong desire. So that is denoted as SD. Okay, then there may be urgency, pain, or fear of leak. These are the additional symptoms which we need to annulate. Okay, then quality checks. patient coughs every minute, and there will be equal rise in the P vesicle and P abdominal. There will be minimal change in the P detrusal. Okay, why there will not be any change in the P detrusal, doctor? There will be equal rise once the patient coughs every minute. There
Yes,
will be
sir.
equal.
Yes, sir.
Why there will be no rise in the P detrusal?
So because there'll be equal rise, it is P detrusor is minus both.
Correct, correct. So normally, if they are stable, then also their subtraction will be same. And if they both rise equally, again, P detrusor will not change. Okay. So provocation maneuvers such as cuffing, heel bounce, jogging, hearing water, uh, hand washing, cooled feeling, and position changes. So these are the various provocation maneuvers that we can perform. And we need to see the bladder compliance also. What is compliance? That is delta volume per delta P detrusal. Okay. Per unit change in volume, how much is the or divided by the per unit P detrusal.
Change in
Okay. Change
detrusor.
in
Yes.
detrusal. That is what is the compliance. If you get a high compliance, that means there is a neurological disease. Okay. So in neurological diseases, you will get a high compliance. Sometimes they can ask you these small questions in the SB. If you get a low compliance, then there may be some damage which may be related to radiotherapy. Okay. Fibrous bladder and all, thick wall bladder. Then stress incontinence diagnosis. Okay, what happens in the stress incontinence? Normal pressure, but leak is seen when the patient coughs without detrusal contraction. There will not be detrusal contraction, but there will be leak when the patient coughs. Okay. So what are the urodynamic artifacts? Artifacts, these are the false reading due to equipment, patient movement, or catheter issues. They are essential to correct them during the test, and common artifacts and their remedies. Sometimes you can get erratic flow curve, which may be because of movement or straining. Ensure the privacy and check for representative void. Okay. There can be pressure drift. Transducer is not zeroed. Okay. So you have to re-zero to atmospheric pressure. Then unequal cuff peaks. There may be catheter kink or displacement. So you have to deposit the catheter. There may be air bubble in the tubing. So fluid fill system issue and expel the bubble. Okay. There can be abnormal P detrusal changes. That they may be because of the catheter which is blocked or malpositioned. So we have to flush the catheter. There may be missing cuff spikes. It may be because of poor technique. You have to repeat the cuff test. So coming to the interpreting the urodynamic report. So when you have the urodynamic test, always integrate the findings with the clinical history, indications for the test, and the bladder diary. So you need to take into account all these things. So automated analysis exists, but must be checked manually also. And you will interpret along with the clinical history, what was the indication for the test and the bladder diary. Always ensure the technical quality comments included and finding reflect patient symptoms and no subtle abnormalities overlooked. So it is not only the trace which we have to report, but that reporting should be along with the clinical history and the bladder diary of the patient. Okay. So the medical legal importance is that particularly with mesh and tape litigation, you need to have this urodynamic trace which is done. Okay. So before planning any invasive, or if there is any failure or repeat surgery, then also you will always have this urodynamic test which is done. So International Continence Society Good Urodynamic Practices 2016 provides a standard reporting template. So there is a standard reporting template also. Now what if you are doing a urodynamic test, but your test is not answering your question? We have already seen we will always have some question for confirmation of the diagnosis or for ruling out the diagnosis. But if your urodynamic testing is not answering the question, then one thing is that if results do not match the symptoms, you have got result, but it is not matching with the symptom. Okay. So check for the urodynamic artifact first related to the equipment or setup issues. Second, as per the good urodynamic practices, repeat the test immediately if results do not fit the patient's clinical picture. Okay. Confirm that the catheters are positioned correctly, transducers are calibrated, and representative wording was achieved. Okay. So you can repeat the test and check for the artifacts if the results do not match with the symptoms. Now, second, what you can do the additional test if the diagnosis is not clear. Means you have performed the urodynamics, but still the diagnosis is not clear. Then there are some supplementary tests after the standard urodynamics. So these tests you will do after the standard urodynamics. Isolated these tests primarily you will not do. Okay, in which you have PAT test. Okay, so the PAT test will quantify the leakage. It will be helpful when urodynamics are inconclusive or not accepted by the patient. Okay, so, say for example, urodynamics is showing leak, but the patient is not convinced. In that particular case, if you perform the PAT test, which will quantify the leakage. Okay, so another test is a video cystometry. It visualizes the functional anatomy, uses contrast and X-ray or ultrasonography. Then ambulatory urodynamics you can do, that will test in natural environment. Okay, that is ambulatory urodynamics. What we do this standard urodynamic testing is in the artificial setting. Okay, so ambulatory urodynamics are performed in the natural environment, useful when conventional test fails to reproduce the symptoms. Urethral pressure profile test, this assesses the urethral closure function, routinely not recommended. It has got a poor sensitivity and specificity. Okay. Now, PAT test. PAT test will quantify the leakage only, but it is not diagnostic. Okay. There are two types of PAT test. One is a short-term PAT test and another is a long-term PAT test. Short-term PAT test is for 1 hour. Patient will wear the pre-wear pad and 30 minutes of physical activity will be advised, and based on the fixed bladder volume for accuracy. And the test will be positive if the pad weight increases more than 1 gram. Okay, so at least 30 minutes of physical activity will be given, and then the pad is measured. If there is a more than 1 gram change in the weight, that means the test is positive. The long-term pad test will be almost for 24 to 48 hours. It is performed at home. The patient continues the normal activities. Okay. Here, there was a 30 minutes of physical activity which was advised. Here, the patient will continue the normal activities. And pad is changed every 4 to 6 hours. Okay. But pad needs to be weighed immediately, or if you are going to store, then store in the airtight container for later weigh. And test is positive if the weight increases more than 1.3 gram. Okay, so these are the pad tests that will quantify the leakage. Okay, then second is a video cystometry. These are the additional tests when your urodynamics is not answering the question. These are the additional tests we might have to do. Video cystometry uses iodine based contrast instead of saline. Okay, once we say about iodine or contrast, we are worried about the allergy. Always we need to discuss this particular issue, take the history of allergy if you get such kind of patient. Okay, then allows X-ray or ultrasound imaging of the lower urinary tract. It is used selectively because of radiation exposure, contrast allergy risk. So not routinely perform. Selective use is because of the radiation involvement and contrast allergy risk is there. It can be used in children, suspected multifactorial causes in neurogenic bladder. It will detect the vesico-ureteric reflux, detrusal sphincter dyssynergia, bladder urethral diverticula, fistulae, and bladder herniation can be detected through the video cystometry. Okay. Now, ambulatory urodynamic monitoring, that also we have discussed in brief, that is conducted in natural daily life conditions, not in the artificial conditions. Okay, that is why it is called as ambulatory urodynamic monitoring. It is useful when conventional urodynamic fails to reproduce symptoms. It allows physiological bladder feeling, privacy during voiding, and assessment during normal activities, walking, lifting, etc. Then another test such as urethral function tests are there. Okay, this can be done during cystometry or voiding. ICI-DCDT does not recommend these tests to be done alone. It has got a poor sensitivity and specificity. So urethral pressure profilometry, UPP, the catheter is withdrawn along the urethra and the pressure curve is generated. So they use the catheter which is inserted into the urethra, and that catheter is gradually withdrawn along the urethra and the pressure curve is generated. It will measure about the absolute urethral pressure and maximum urethral closure pressure. The clinical value is limited due to high test and test variability. Should be used only as an adjunct to the standard urodynamics. Again, these tests are done as an adjunct along with the urodynamics. Okay. Conclusion is that appropriate use of urodynamics is valuable only for the right patient. It must be combined with the detailed history, examination, quality of life questionnaires are important, and the bladder diary. All these things we need to take into account along with the urodynamics. And we need to have a clearly defined the clinical question before testing. Always minimize artifacts to ensure reliable results. And if inconclusive, then decide which supplementary test provides the next useful information. Okay, so if your urodynamic is inconclusive, we might have to go for supplementary test, which we have seen. It may be PAT test, it may be video cystometry, it may be urethral pressure profiling, UPP, or it may be uh, ambulatory urodynamic. Okay, so these are the additional tests. Okay, so there may be some question on this diagrammatic question. Here you see a bladder diverticula. Okay, so the this is the lining of the bladder. So bladder diverticula seen on video urodynamic. So what kind of test is this? This is video urodynamic and showing the outpouching of the normally smooth bladder wall are delineated with their contrast medium. Okay, so here you see the bladder diverticula. So the diagnosis will be bladder diverticula. Okay, so when you are interpreting the test, always look for the calibration, whether is the subtraction adequate. That means P abdominal, P vesical, and retrosal pressure should be within normal range before commencing feeling, and checked each minute as the patient is asked to cough. So before you start this feeling, you have to check this. There should not be any change in the detrusal when you are not feeling the bladder. When you feel the bladder, then there might be change in the detrusal, but without feeling, there should not be any change. That is, before you start, you have to calibrate it. Okay, check that there is no change in this particular pressure. Okay, then feeling and storage phase, you will assess the involuntary retrosal activity, bladder compliance, sensation, continence, and capacity. That you will assess during the feeling and storage phase. Okay. Then P retrosal, already I have mentioned, if there is a rise more than 15 centimeter or not, that you will note it down. If there is a rise in P retrosal, what is the pattern of rise? Whether it is provoked or unprovoked. Okay. It may be provoked or unprovoked, rise in retrosal pressure that is abnormal and would correlate with the overactive bladder. That means you are dealing with the overactive bladder. Okay. Are there any sensation? Means whether it is associated with the urge to pass the urine, that also we need to note it down. It may be associated with the sensation of urgency, which would correlate with the overactive bladder. Okay. Evidence of leak with the provocation with no rise in the P retrosal. Okay. That is suggestive of stress incontinence. So in stress incontinence, there will be leak without provocation. Okay. There will be rise in the intra-abdominal pressure, there will be rise in the vesical pressure, but there will be no change in the detrusal and there will be leak. Okay, that is suggestive of stress incontinence. Then capacity, whether it is normal, increased or reduced. Voiding phase will assess the contractility of the bladder, emptying of the bladder, coordination, and any evidence of voiding obstruction. And then voiding Vmax, is this normal? That also we need to look into it. So this is the urodynamic stress. So you see this one particular line, which is blue, that is P vesical. Okay, this the red line which you see is a P abdominal. Okay, and this is the green line is nothing but the P detrusal. Okay, now what is this chart is showing here? See, what you see here, there is a rise in the pressure. Here also there is a rise in the pressure. And what happens to the P detrusal here? Not much rise like this. Okay, this is the feeling and voiding systemetry showing the unprovoked rises in the detrusal pressure. Here there is a rise in the detrusal pressure. These are the blue arrows associated with the sensation of urgency. Okay, so these are unprovoked rise. This is a suggestive of bladder overactivity. Okay, so this here they are see, this is a cuff induced. Okay, so there is a rise here also, and minimal change here. But here, these are the changes which are not provoked. There is no cuff. Here there is a cuff. Okay, here it will be cuff induced. Here it will be cuff induced. But there are no such provocation, but still there is a rise in the detrusal. Okay, this is associated with the sensation of urgency, suggestive of detrusal overactivity. Okay, so FD stands for first desire to pass urine. SD stands for strong desire to pass the urine. Okay, ND stands for normal desire to pass the urine. Okay, so these are the things you may get such kind of trace in the examination, and they will ask you the reporting. So here, what is the diagnosis? Is a detrusal overactivity because there are unprovoked increase in the rise in the detrusal pressure, and this detrusal pressure should be more than 15 millimeters. So here it is around 23 plus. Okay, so here you see 0, here it is 23. Okay, so there is a rise in the detrusal pressure. Now here this is another trace. Here also you see that this is a P vesicle, this is P abdominal, and this is the P detrusal. Okay, and here is the voiding phase. At the end is a voiding phase, and this is the start of feeling. Okay, here there is a cuff. Okay, patient is cupping here, cupping here. So along with the cup, you will see the changes in the P vesicle and P abdominal, while the P retrusal is normal. Okay, there will not be any change because these two will get subtracted. So this there will be no change in the P retrusal. So 1, 2, 3. Here also you see equal everything. Okay, so but there is no change in the period. That is normal. Okay, then this is normal desire. ND is a normal desire to pass the urine. This is FD. There is a first desire to pass the urine. This is the strong desire. SD is a strong desire to pass the urine. MCC is the maximum systometric capacity. Okay, so this is the overall normal. Okay, so what does this figure show? It is a normal cystogram with a feeling and voiding phase. Okay, so this is the feeling phase and this is the voiding phase. Okay, here it is the start of feeling. And how much should be the feeling rate? It can be 10% of the total voided volume. Okay, so this is the normal aerodynamic. So you always look for the here this change in the detrusal pressure, and also look for these provocations. Okay, so that finishes the topic of aerodynamics. Thank you.